So, sir, you can start now, sir.
Thank you.
Good evening, everybody.
Assalamu alaikum. Good evening, respected audience and dear participants. Welcome everyone. Today's Cathlab manual series 12. Today's topic, everybody, how to deal with calcified lesion. We are very much grateful. Dr. Shirish Hiremath, everybody, all the, I think, mid-level cardiologist or senior cardiologist, know everybody. He is so much popular in Bangladesh. He's the extraordinary interventional cardiologist, but one of the most thing, he's the most humble and gentle cardiologist ever seen. We are IPDI grateful to your kind presence here. Everybody, just a little contribution, just small introduction. Dr. Shirish Hiremath is the director Cathlab, Ruby Hall, Pune. He was president CSI 2017, also program chair CSI conference 2016. He's convener National International Council of India 2004 to 2006. He doctored to many interventional cardiologists and has been given live courses across the globe. We are everybody Bangladesh, also all the centers. You work in the National Heart Foundation and ICBD, also UDM Cardiac Center. Great experience in peripheral angioplasty, including legs, iliac, and carotids. Participates in some groundbreaking trials. Thank you, everybody. Welcome, Dr. Shirish Hiremath here. I am requesting our chairman, Professor Abdul, please opening remarks and start our session. Professor Abdul Chowdhury.
Assalamu alaikum and good evening to everybody. Today, we are going to hear about the calcified lesion. Calcification is just nemesis for the cardiologist, interventional cardiologist. You think you see a lesion, you think you can do it within 15 minutes, and then you find out that it is so calcified, it took you 1 hour and a lot of stress and everything. So that's the point when a young fellow particularly comes across a calcified lesion, how to deal with it. And if you have resort to rotablator or every other thing, IVL, opium balloon, very high pressure balloon, you can do it much more easily. When you don't have all those things, then how can we achieve success? Dr. Shirish Hiremath is a teacher. He's an intervention cardiologist, no doubt, but moreover, he's a teacher. And he's so popular here, as Mohsin was saying, because he loves teaching, training others how to achieve success. And I hope we really enjoy his presentation, and our young fellows and as well as us also will learn how to deal with calcified lesion from him when we don't even have the rotablator or something like that. Thank you, everybody. Professor Hiremath, the field is yours.
Thank you, sir. We have another two speakers here. Dr. Sahela Nasrin, he is the Associate Professor of Cardiology in the UDM Cardiac Center. Also, Dr. Kalim Uddin, he also Associate Professor of National Heart Foundation. Both are working with the Shirish Hiremath. They are also experienced there. Thank you, sir. You can start your session, sir.
Good evening, everybody. We are in India half an hour behind Bangladesh time. Dhaka is one city which I always love because you people are so friendly. It's an overwhelming welcome every time I visit Dhaka. And I have very, very fond memories of Dhaka and people with whom I have stayed, worked, and sort of learned together on some complex cases. If you see the history or course of angioplasty, how it has grown, you would realize that angioplasty approached simple lesions first, then multiple lesions, then complex lesions, bifurcation, left main. So these were conquered one by one. Today, what we still struggle is the CTOs because it needs different kind of techniques, and also the calcific lesions, which are very hard to break, hard to sort of expand. And that is where I think we take help of surgery sometimes. However, let us see in today's presentation some innovations which have happened, which makes even calcific lesions can be addressed. So we are going to talk both lesions addressed with as well as without rotablation. So whenever we talk of calcium, we talk of superficial calcium, deep calcium, and nodular calcium. So superficial is close to the lumen, deep is outside towards the adventitia, media and adventitia, and nodular calcium is most of the surroundings may be good, but you can see a vessel which is protruding from one side, the wall is protruding. So these are most difficult to address, and still we don't have a 100% solution. In fact, a few angioplasters coming together will always debate on what is best for nodular calcification. So we are going to see how to diagnose and how to treat these. Once we have sort of, you have to make a judgment whether the calcification is extensive or it's a very limited focal area calcification. So in presence of intravascular imaging, you can sort of make a good decision as to how much is the length of the calcium, how deep is the calcium, and what is the strategy that we are going to follow. Now, this is important because this slide shows that as the severity of calcium increases, worse is the outcome. So you can see in these brown or red bars, this is severe calcification, and yellows are mild to none. So almost threefold increase in the mortality rate. Even the MACE rates almost jump twice from mild calcium to severe calcification. So it sort of makes you and I understand that moment we talk of calcified coronaries, or for that matter, calcified aorta, calcified iliacs, calcified carotids, we are going to be dealing with a tougher subset, and probably new techniques would be required. Now, this is what typically happens if you don't prepare the bed before you take a stent. So here, this particular area was not prepared, not pre-dilated well, and a stent was placed. The stent did cross this portion, but once the stent has crossed, you can see on stent boost that the stent is failed to expand. So here you would probably take a small NC balloon and go on upsizing this NC balloon and get a full expansion. However, one should never run into a situation like this, that the stent is deployed and is not getting expanded. Here is another case. I'm going to show you a few cases so that you and I understand what has gone wrong and what can be done to improve our results. So this is a case done elsewhere about 14 months back. And this patient has a stent from left main to LAD. Now, if you see the left main to LAD flow, it looks quite good. However, the side branch, the LCX, has got a critical ostial stenosis. So this is an ostial stenosis. And mind you, this is not a simple circumflex. This is a very, very dominant circulation, and a huge area is dependent. So it's no surprise that when patient has this narrowing, he has angina on minimum effort, occasional rest angina, and the patient has come to us. So when we image this patient and what looked like a reasonable left main to LAD flow, you can see the stent, and stent is clearly unexpanded on IVUS. So here is a stent which is deployed, and stent is not touching the vessel wall, so it's under deployed stent. And this could be one of the reasons why the side branch also is sort of getting caught into the ISR. Many times we address the side branch with a balloon to open up the stent strut so that the flow to this is well maintained. Even that balloon can traumatize the tip of the side branch. So when we take this patient for angioplasty, we had to prepare the bed aggressively. So this is a OPN balloon. We will talk about this OPN-NC balloon, which is a very high pressure balloon. It can take pressures like 45 and 50. So we used OPN-NC balloon to prepare the bed here, then put the first stent from ostium of left main to the circumflex, did the first culottes, and then put another stent because the stent towards LAD was under deployed on IVUS, as I showed you. And this is how we ended up this particular case. So we had to do a delayed culotte with the old stent, which was 14-month-old. And since that stent had not expanded fully, we had to put one more stent. So you can see the old stent here is in yellow, 2016, and 14 months later, 2017, we have put first stents from ostium of left main to the circumflex. This was a dominant circulation. And since the old LAD stent was not expanded well, we have put one more stent in this area. And you can see a very nice bifurcation in the LAO caudal view. Many people like to use LAO caudal view. I think it's a very good view to work for the left main distality, left main bifurcation, and the entire left main length. However, when you want to talk about the ostium of the left main, I would strongly recommend taking a LAO cranial view. So you go about 30-40 degrees LAO, 30-40 degrees cranial, and that shows the ostium of the left main the best. So this view must be used when you want to deploy the left main stent at the ostium of left main. So this is what we call as a delayed culotte, delayed double culotte. So when we have calcium, the greater, which is seen on IVUS or OCT, if it occupies a sizable arc, it's a reasonable length. So you calculate whether it's 180 degrees or 270 degrees. Then you calculate the length of the calcium and then the thickness, whether it is 2 millimeter deep or 5 millimeter deep. And that sort of tells you right in the beginning what you're in for, and accordingly you can make a choice of different material. So if you have calcified vessels, you clearly worry about malapose stents. Here you can see the stent is deployed, but it is not touching the vessel wall. So this is a malapose stent. The malapose stent can be a nidus for in-stent restenosis, and thus these stents are very prone to ISR, and also for stent thrombosis, which may happen not in the cath lab, but maybe 2 days later or 5 days later. So all these have to be taken care of when you're talking of a calcified vessel. So this is again talking of stent thrombosis, and all these blues are actually issues where you expect stent thrombosis due to a malapose stents. When we talk of calcification, I think CT coronary angio is quite important. These days, many patients comes to us before we do a catheter angiogram with a CT, and it's always good to look at the CT angiogram because it shows the calcium very, very well. You can sort of differentiate whether the calcium is on the adventitial side or it's on the inner side along the lumen of the vessel by taking a cross-section view at this site, and thus sort of prepare yourself mentally as to what you're looking for. The CT coronary angio has advanced, and the ischemia study, which was presented last year, highlighted a big gain for CT coronary angio. And now we are in a position to add non-invasive FFR. So this is anatomy and this is physiology. And by doing this combination, before you take the patient to the cath lab, you are already mentally ready and the family is also ready that the patient is likely to need all these when we take the patient for angioplasty. Now, CT angio has a very good futuristic attitude also. It can sort of tell you how much is the calcium, and various scores which we are used to, like Framingham score, UKPDS scores, they are falling short as to the prediction offered by CT coronary angio. So if there is a CT angio done, I think get that information to the cath lab, because based on that, you can see your access, whether your aorta is calcified. You can see the lesion and you can see the cross-section of the lesion. And this is a napkin ring calcification, which is again tells you that this lesion is likely to be important because it can give you an event in near future. So these kind of look at the wall of the vessel is also important. In conventional angiogram, we look at the luminogram and the angio does not show much about the vessel wall. But a CT angio also tells you by taking cross-section a little bit more about the vessel wall, which is going to be useful. I will show you one case where FFR is again coming useful in sort of making a prediction. Now, this patient had a highly unstable angina coming from this ulcerated proximal LAD lesion. When you sort of look at the other tree, coronary tree, you can see apart from this lesion, the bifurcation of left main is also showing some degree of atherosclerosis. Whether this is important, this is a question mark at this stage. Whether this OM lesion is important, this is again a question mark. So what we did is put a stent here, and after putting a stent, we applied physiology by doing an FFR. So when you put a wire in the LAD, the FFR wire, the FFR as shown here was 0.73, and the FFR in the circumflex was 0.74, which meant that the artery flowing towards circumflex and towards LAD, both are still showing significant narrowing despite a stent in this area. So that means this area is probably giving an important narrowing. So it sort of tells you that after doing the LAD stenting, here we need to address the left main bifurcation. So this left main bifurcation is done by culottes technique. So this patient, we thought initially would need only one stent, received a left main bifurcation based on physiology assessment done by FFR. So this is how this particular case went. We put the first stent. This was important because only when you take out this lesion, the FFR to LAD becomes realistic. So after doing this, the FFR was positive in LAD as well as circumflex. So next stent was placed in the left main to LAD, starting at the ostium. Then we do a pot where a short length balloon is used, big diameter at high pressure. And doing pot, the access to the side branch, which is OM, was easy. We do a pre-dilatation and then do a culottes. Like you can see in culottes, these two stents are overlapped. We do a final kiss and get a nice result. So when you talk of calcification, take help of all the modalities, like patient, if you said already a CT angiogram, it tells you how much is the calcium. This is non-invasive. Important thing is it takes a lot of contrast, almost 80 cc of contrast. So if your patient is long-standing diabetic, has typical angina, I wouldn't send him for a CT angio. I would take him to a cath lab. The contrast, most of the CT coronary injection requires 80 cc of contrast, which is quite a big contrast volume. In contrast, the conventional catheter coronary angiogram can be done in about 30 cc's of contrast. However, this is invasive techniques. The calcium location you can see along the vessel, but you cannot say whether the calcium is on the adventitial side or whether it's on the luminal side. You move to IVUS, which is an ultrasound, and this is a sure way of finding out calcium. You can see this bright white calcium along the entire 360 degrees of the vessel. You can also measure the depth of the calcium, but if there is a lot of calcium here, the calcification in the background becomes not very clear when you image with IVUS. So this is probably a little limitation. The good thing is, though it is an invasive technique, you don't have to inject contrast, so no contrast is required. The deep calcification, as I said, I mean, if you have calcium along the lumen, it sort of interferes with assessment of deep calcification. And this deep calcification is best studied with optical coherence tomography or the OCT. Now, OCT has a very high resolution, so the images look absolutely pretty. And you can see a stent place, stent expansion, and you can derive so many conclusions based on what you're seeing on an OCT. However, every time you want to pull the OCT catheter, you have to inject contrast. So clearly, if you do 3 runs of OCT during one cath lab procedure, you're injected at least about 30 to 50 cc of contrast, which is apart from the usual contrast that you would use. I'm showing you one case, and here again, the left main to LAD stent is placed. This was in a peripheral hospital and they had no imaging. The operator felt that he should do something to the side branch, which is again a very dominant circumflex circulation. So he put a balloon to the side branch and did a kiss. And this was his final picture. He was obviously not very happy with the mouth of the circumflex, but he decided to stop at this stage. And as very predictable, within 2 months, the patient has come back with angina. You can see the flow from left main to circumflex has closed off. As I indicated, this is a dominant circulation, and the entire circumflex circulation is filling up through collaterals coming from LAD. So obviously this patient cannot go on with conservative medical treatment, and we decide to offer him an angioplasty. So we used this Sasuke catheter. In Sasuke catheter, you have a terminal hole for the wire. So this tip goes over the OM1 wire, and through the side hole, which is a few millimeters behind the tip hole, you can push your wire on the side. So the first wire is in OM, the distality of the Sasuke catheter, which is like a microcatheter, is towards this branch, and through this hole on the side, a few millimeters back from the tip, you are pushing this wire. So this is a very easy way to access a difficult side branch. In this particular case, this side branch had closed off, so this kind of help was really required. And then you do a T and protrusion on this case. So you prepare the bed, with a regular balloon, a non-compliant balloon, a cutting balloon, whichever way you want. But I would be very aggressive on this because circumflex ostium is very notorious for re-narrowing. As it is, we're addressing an ISR on the side of the first stent, and this is why we used everything and then put a stent as T and protrusion. So the yellow one, number one, is the old stent, which is 2 months old, and the blue one is the new stent. You could have done a culottes also and brought the stent back, but we thought we'll end up with a design like this. Now, in this case, you can see a ostial LAD lesion. So we thought we'll place one stent at the ostium. As you can see here, the stent is in position, and then we would address the circumflex with another stent. Somebody could have done the circumflex stent first, and because once you place an ostial stent, sometimes going to the side branch does become difficult, especially if the stent is protruding a little bit towards left main. However, since we had some cost constraint on this case, we decided to do it like this, so that in case if there is some issue at the mouth, we can put just one more stent from left main to circumflex. But while doing this, we can see after putting the LAD stent, you can see on angiogram a dissection flap. Now, mind you, this was not easy because all other views did not show anything. They showed a normal flow in the left main. Only when we saw this particular angle, we could see this. So we decided to do an IVUS, which confirmed the flap. And then we did an OCT. Again, this confirmed the flap. And when we decided we'll put a stent in that area. So the stent from circumflex was pulled back to the left main. You can see the, as I told you, LAO steep cranial is the view to place your circumflex stent. So always take this view, steep LAO and about 30-40 degrees steep cranial and about 30-40 degrees LAO. And this, by doing this, you will not miss the ostium. See, it's very risky to position your stent left main at the left main ostium in LAO caudal view because this foreshortens the entire length. So always take this view and then you sort of make a judgment. So this is how we did. The third modality that we use is the OCT. Again, an expensive modality because the OCT catheter is quite expensive. But see the kind of images. It shows the lumen very well. There is a dissection here. You can see the atheroma and you can measure the depth of the atheroma and so on. All these, the angle, how much is the calcification? Like in this case, this is a 360 degrees calcification. And this will help you decide what strategy you would choose. The OCT is also extremely useful to assess the stent expansion after you have deployed the stent. So if you have used a pre-assessment OCT, you must use the same catheter and do an assessment. And you can see the stent is well adherent to the vessel wall, so it is a well expanded stent. This is an angiogram, but once you know do OCT, you can sort of make out if it is well adherent to the vessel wall. So the OCT can sort of, this is an ISR, and you can see on the OCT, the old stent is here, and there is a lot of ingrowth which is narrowing the vessel. So the stent is well expanded, but there is a gross hypertrophy of the intima and immediate intermediate tissue, and that is how the vessel is narrowed. So whenever you're dealing with ISR, you must do imaging because it clearly shows what is the cause of ISR. In this particular case, the old stent is expanded very well, However, there is an ingrowth, so you need to choose a technique which is based on this ISR. Now, in this case, we have put a long stent in the LAD, and you can see here the side branch is kept open by doing a small balloon dilatation to the side branch through the stent struts. So you can see on OCT, the stents, white dots are stents struts, which are well opposed to the vessel wall, and stent is thus fully expanded. And you can see this is the position of the diagonal branch, and you can rotate this image in various angles to make sure the mouth of diagonal is open. So this is a kind of comparison between IVUS and OCT. The IVUS shows these bright spots of calcium. So if you have a luminal calcification just around the lumen, it is best assessed by IVUS. If you have a deep calcium, it is best assessed by OCT. OCT also shows this kind of protrusion, and this is very difficult to address with current techniques that we have. So this is the overall comparison between the conventional angiogram. You would see you have only a single plus here, while CT angiogram has 3 plus. The IVUS has 3 plus, but if you use IVUS with histology, these bright white spots show calcification. So the sort of accuracy improves when you use this virtual histology, VH, IVUS VH. And of course, OCT can tell you a lot more compared to any other modality at this stage of time. Now we have this rotablator, which many of you must be used. This is there for almost 2 decades. But we also now have this shock wave balloon. I think if you see the technique, this is a little bit more user-friendly. You take it just like any other balloon with some degree of bed preparation. You inflate the balloon to 4 atmospheric pressure. And this length at the moment is 12. And you have sizes going from 2.5, 3, 3.5, 4. So these are the different diameters that you are available. And you can see every time the ultrasound wave is emitted, the calcium is getting pushed. If you concentrate on the atheroma, which is calcified, you can see with these ultrasound waves, the calcium is getting softer and getting pushed with the balloon. When you talk of rotablator, all of you know that rotablator has this drill, and this drill actually cuts through the calcium. It is like we use this drill to make a hole in the wall of the house to hang a calendar. So this drill actually rotates, and it sort of makes space by cutting the calcium, and then you can use a balloon to further expand. So this is an old technique, which is more than 20 years old. We've been using shockwave for just about a year now. And the other things which are also available is a conventional balloon, which is a compliant balloon. Then we have a non-compliant balloon, which adheres to the vessel wall or the diameter specified. You have a cutting balloon, which has got a blade on one side. So it actually cuts through the atheroma, and this also has its own role. Or you have a scoring balloon, which is like a wire going around the balloon, and this wire cuts into the atheroma. So at the moment, we have these few things available to us, and I'll talk about the OPN balloon soon. So you have these high pressure non-compliant balloon, NC balloons. Then we have this OPN balloon. We'll see in details what it is. And what we have not talked about is the laser and the orbital atherectomy. So this is actually a rough comparison between the lithotripsy balloon, IVL, and the ultra high pressure balloon. The good news for the young interventionist is the learning curve is quite short. Like if you are to learn Rotablator, you'll probably need to spend some months trying to perfect the technique. But for all these, those who are used to balloon stent techniques, they would find a very short learning curve. The IVL balloon is used more for preparation of the bed in calcified lesion. So it is a pre-stent kind of balloon most of the time. And the ultra high pressure balloon or the OPN balloon is used for optimizing the stent at high pressure. Then we talk of slow flows like in Rotablator, but all these balloon techniques, they generally never have slow flow. So this is a low risk, and thus it can be used in ACS situation quite effectively. In this case, you have a bifurcation of the LAD and diagonal. The diagonal branch is also quite a big branch. And you can see we need to sort of do a rotablator to the LAD, and we don't want to withdraw the wire. So you put a flex tom cutting balloon on the side, and thus without withdrawing the wire, we make the lesion preparation and end up with a two-stent technique like this. So we have already seen this, and this shockwave balloon, like this patient had a RCA lesion, and this shockwave balloon has to pass through. So most of the time, you need to do some pre-dilatation with a conventional balloon, and then take this shockwave balloon, which sort of emits the sound wave, which hits the wall and thus softens the tissue. The other things that we use for calcified lesions, we talked about rotablation, but there is an orbital atherectomy which is not available to us in India, and then excimer laser is just introduced in last few months in India. So these need some kind of technique. They modify the plaques very strongly, and the laser actually, when the lesion is hard to cross, like a chronic total occlusion, this becomes very, very effective technique. Like in this case, you have a very tortuous RCA, very critically narrowed. Getting wire down was quite difficult. And we couldn't cross with balloons, so we finally decided we'll do a rota. So as we did rota, we had huge ST elevation, slow flow, no flow, emergency kind of situation, because all this muck which was here before probably had a thrombus, and this thrombus, along with small particles of calcium, it migrates, it blocks the microcirculation. You are expected to dilate these with multiple small bolus injection. And this is how we salvage. So final result was quite good. But then this same patient needed a LAD rotablator. So many would have probably staged it, but because of some insurance rules, we were forced to do the complete procedure in one go. So here, instead of using a rotablator, because we had a lot of distal embolization on the RCA, we used OPN balloon. So when you use this high pressure balloon, we generally use a size which is half size less than the vessel diameter. So vessel is 3, you take 2.5, go to a 4 atmospheric pressure first. You can climb to about 20 as you would do regularly, but beyond 20 to 45 or 50, you go slow. Keep watching the looking at the balloon, and then we were able to achieve a nice result even on LAD. So distal embolization is the least possibility with this kind of technique. So this is again a left main LAD circumflex bifurcation. Circumflex again is a large circulation, as you can see here. So you have to be very careful that you do not pinch the side branch, do not embolize into these vessels. So you do a rota. When you do a rota, you initially do burring with a slower speed, 160,000 or 150,000. Once you have made a sort of forward movement across the lesion, then you can do the polishing with a higher rotation speed. So 150, 160 in the beginning, and once you cross, you bring back the burr, and these final finishing touches are done with a higher speed. Always keep injecting dilators when you're using these, and then do whatever techniques that you want to use. So the rotational atherectomy, orbital atherectomy, and excimer laser, they have a lot of learning. You need to sort of give a lot of time to make a perfect job. Now, this is a patient who came to us. An angioplasty was attempted in a peripheral hospital, a smaller town, and they had only balloon and stent as an option. So this was the picture. The stent the balloon just could not break the waist or the stent, waist or the lesion. So we had these background information. So we do a rotablator to this, and then you can see as you go up on inflection on this 3010 NC, the sort of balloon yields and you get a full expansion. Only when you get a full expansion, you should put a stent. So the previous operator in a small peripheral hospital was absolutely justified in stopping at this stage because he could not get a stent, balloon fully expanded, and he did not have any tools. One could do, if you have no other tools, what you can do is place another wire on the side, what is called as a buddy wire. It might act as a cutting wire. And when you inflate, the wire will cut through, and then you can get a good expansion. So this is the kind of result we got on this stent. So when you have the multiple side branches, like in this case, there was a distal main LAD ostial lesion, and the circumflex was a dominant vessel. So we decided to use this kind of strategy. First stent here, TN protrusion towards the OM1 branch, and another TN protrusion on the LAD, and ended up with this kind of result. Now, this was possible only because the imaging had shown no calcification at this site. So conventional balloon and stent is a good option, and you end up with high pressure, non-compliant balloon inflation, doing a KISS with at these two sites, and you would get a good result. However, look at this 78-year-old long-standing diabetes. He had this very, very critical narrowing at the distality of left main and in the LAD. So we did a rotablator to this and put you can see the stent coming back from LAD to left main. However, the ostia of both these branches, one here and the circumflex, they were showing critical narrowing, and we decided to put a stent there. So the bed was prepared, and the strategy was planned like this. This was the main branch stent, LAD to left main, and we attached two stents on the side and ended up with a good result on this case, as you can see here. So you may have to change your strategy and switch to some other strategy as we go on. So you can see a very sort of negative shadow here. We are not sure whether it's calcium or whether it's thrombus. Patient had sort of angina for about 2 months. And we thought we tried imaging, but the imaging probe could not cross. So we thought it's safer to use a balloon because you don't have to withdraw the wire and distal embolization would be much less. So we do a balloon, OPN balloon. We take very high pressures, one towards LAD and one towards circumflex, and then do culottes in this particular case. I think it is culottes to get a decent result. So when you talk of calcium, you have this very high pressure balloon, 45 to 50 pressures it can take, the OPN. The rotablator has been with us for a few decades, so I think most of us are familiar with this. We have these cutting balloons and we have this IVL. If you see the positivities, you can see IVL has lots of positivities. So I guess if you have a deep calcification, this becomes your option of choice. If you have superficial calcification close to the lumen, you have rotablator as an option. And sometimes you have superficial as well as deep calcium. So you do rota and then you do IVL balloon, what is called as rotatripsy. So you can do combinations in various ways to get results like this. So a little bit about this OPN balloon. It has a fairly narrow entry profile, so it can get in easily through a minimal opening, which you may have achieved with a non-compliant balloon. Overall balloon profile is less, and it has this double layer. So even when you go high pressure, if the inner layer gives way, you have an outer layer which does not allow the contrast to come and hit the vessel wall freely. So you will you might get balloon perforation, but you will not get a vessel perforation. And that is the safety which this balloon can offer. A conventional balloon, when you inflate, if the lesion is giving a lot of resistance, the dog boning effect is seen and you see the ends continuing to inflate, while the OPN balloon inflates very uniformly. And this is what happens as you increase the pressure in the balloon. The non-compliant balloon grows in size. The semi-compliant balloon does grow, but much less compared to a non-compliant balloon. And the OPN NC balloon hardly grows in diameter. So this is one reason why the OPN balloon does not perforate the vessel. Now you see a very tight lesion at this point. You have a dissection. The dissection actually spreads for a long length in the distality. So under these kind of settings, the rota becomes relative contraindication. So we can use an OPN NC balloon. We covered the entire length with the stent and came out with good results. So OPN NC balloon, the 3 hardly grows even when you go to high pressures like 35 and 40, while the conventional balloons can continue to grow. One trick when you are using a OPN NC balloon is you should avoid polymer, avoid wires which have these hydrophilic coating, because whenever you use very high pressure, the balloon inside has a tendency to grip on the wire. It will pull out the wire as you're pulling out the balloon. So consider putting a buddy wire on the side if your wire which you cross with a lot of difficulty is a hydrophilic wire. So in calcified lesion, very often more pressure is required than more diameter. So if you have a 3O vessel which is not opening up easily, go to 2.5 OPN balloon and then go high pressure. I think I'm coming to end of my vessel. my talk, but I also must tell you that the OPN balloon, like in this case, we had a lesion at the left main distality and here. So this was done with a rotablator, but the diameter required here was 1.75, which was too big for this. And we did not do a rotablator here, but we used a cutting balloon, and then we put a stent. Now this stent was deployed with a 3.5 OPN balloon, which is obviously not the diameter of this vessel. Though we went only to 10, you can see the vessel perforated. So in general, it is a good balloon to avoid perforation, but never overdo. And then you can choose a lot of these combination rota with a high pressure OPN balloon, rota with a lithotripsy balloon for deep-seated calcification, a cutting balloon plus a high pressure OPN balloon, and so on. So this combination sort of makes things easy for you. These are various algorithms. I don't think we have time to get into details, but yes, you can sort of, I think let me come to an end because I think I have overstayed the invitation. So this was actually a multi-vessel coronary artery disease in a diabetic patient, 72 years with visible calcification. You can see left main and very important vessels, including a very dominant circulation. So here we did rotablator to LAD, rotablator to circumflex, and then of course we had done IVUS, ended up with one stent in LAD, another one LAD to left main, and a third one to the LCX as a decay crush, and we got this kind of result. So whenever calcification, don't be in a hurry to take the stent in. Take your time to prepare the bed, image very importantly, to decide what kind of tool you want to choose, and get a good dilatation, good bed preparation, and then put a stent that you want. So friends, thank you for the invitation. And I'm in this city called Pune. We are close to Mumbai, about 2 hours drive. So we are on the eastern side, no, on the western side of Maharashtra state. Thank you indeed for the invitation. And sorry if I've overstayed the time in giving this talk on calcification.
Thank you, sir. Thank you, sir. It's a great live demonstration of lecture. Both combination of the cases and lecture. I think we are really enjoyed your lecture, and our fellows also, some senior cardiologists here, they are enlightened your lecture. Professor Abdul, sir. Professor Abdul Chaudhury.
Yeah, I was actually mesmerized by the lecture. Particularly seeing the complicated cases you have done so nicely. These are nightmare cases that we used to send to the surgeons. Let them handle this. But nowadays, the intervention cardiologists are doing it very well. One thing I want to know,
Yes.
how can our young fellows from angiogram can suspect that the lesion may have calcification? Some are obviously visible, but some are not. Is there any clue to that?
I think the age of the patient, most of the time age will tell you. Like if you have a 70-year-old in front of you and he says, last 10 years I have heart angina, I think, and on fluoroscopy you see calcification, you should assume that this patient could be having calcification in the vessel wall, and you should be mentally ready. I think many labs have IVUS, which is much easy tool compared to the OCT in terms of usage, in terms of less contrast and so on. But OPN is an absolute glory. I mean, you see so many things so beautifully, so crystal clear. So given a choice, I would always go for OCT imaging compared to IVUS imaging. But both have their own positives and both have their own limitations.
And the question that I'll be asking,
Thank you, sir.
I have a lesion is around 99%, but I think it's a softer lesion. Trying to put a wire through it and then find out it's calcified. What type of wire will you prefer to pass through the lesion when there is calcification?
Actually, a wire probably will not be, I mean, any wire would really go. But if you take a hydrophilic wire, it would be easier to go. But as I mentioned, the higher the balloon pressure, this is not specifically for the OPN balloon, even regular NC balloon, if you go to about 30, it will have a tendency to stick to the wall from inside. So when you pull out this balloon, your wire may come out. And most of the time you have taken huge effort to go through the CTO with the wire. So you feel really deeply hurt when the wire is pulled out by the balloon. Luckily, most of the time it has done its good job. It has dilated the lesion and you can recross. But I think wire choice, if the lesion is 99%, I would take a hydrophilic wire, make some inflation with a compliant balloon, exchange the wire to a regular BMW wire over a micro catheter, and then you can take whatever you want. If you're going to do a rotablator, I would exchange it to a rotawire.
So sometimes better support wire is better to crossing the balloon or stent, support wire, polyester or.
Yes, I think if you realize that the vessel is very tortuous,
Yes,
then
sir.
support wire is going to be very important. In fact, I couldn't concentrate on that, but one of the cases which I showed you, the right coronary, we had options like I like to take a long sheet. So instead of taking a conventional short sheet, my 50 centimeter long sheet will go all the way to the arch of the aorta. This gives support from behind. Take a bigger diameter catheter. Instead of taking usual 6, take a 7F catheter, because this catheter also can give you a lot of support. And to improve your support, as one of you said, that we can take a support wire. These are some wires that are really huge support for the balloon to cross. This is how you can improve. If you want support for the balloon or the stent to go through, then you have GuideZilla or guide liner, which can go deep into the vessel. So the stent has no resistance at all till it reaches the lesion. The other thing which I would like to sort of mention is if you're dealing with a CTO, like this is a CTO location, and if your wire has gone through, and if your balloon has come here, and the balloon is going up to here, and not going further, whatever you do, smallest balloon and so on. So inflate at this spot, inflate. And as you are deflating, before you come to negative, try and push it in. So this is how you're making the lesion soft. And this is actually like caterpillar movement, I call it. So slowly, by millimeter, every time you inflate, deflate, you push it in and you would gain a few millimeters. And this is how a non-crossable lesion also can be crossed with a low profile, something like 1.0 millimeter balloon, you can cross. Of course, there are various competitions between different balloons, and they say my balloon is the best and so on. So I think everybody can make their own choice. But I think we are with the conventional balloon, and they work beautifully in these cases. I mean, it would be very disheartening that you spend half an hour to cross a CTO and then nothing is crossing. Under these kind of settings, you need to sort of use all these extra push techniques from behind, which would help. The NIC nano hydro balloon, which I mentioned in one of my slides, it's a small length balloon. It's less than 1 centimeter length, and it's 0.85, and it is not a compliant balloon. It is a non-compliant balloon. Normally, non-compliant balloon, they can't have too much pushability, but this particular balloon, 0.85, is the cross-sectional area. It can really go through very easily. So I think the angioplasty is clearly advancing to the betterment of the patient and to our betterment too, because we can come out with good results. We can come out with a shorter stay in the cath lab and so on.
Thank you, sir. Dr. Khaled Mohsin, sir. Dr. Khaled Mohsin is the co-chairman of IPDI. Dr. Khaled Mohsin, do you hear me? Dr. Khaled Mohsin? Professor Dr. Khaled Mohsin, sir. Okay, I think he's disconnected. Dr. Kaisa Nasrullah Khan. Dr. Kaisa Nasrullah Khan, do you hear me? Dr. Kaisa Nasrullah.
Yes.
Yes.
Assalamu alaikum and good evening to all. It's a wonderful lecture. I learned a lot. And I think in interventional cardiology, last frontier to win is CTO and calcified lesion. This is the toughest challenge which interventional cardiologists face. And to win it, you can, this is the reasons to send patient for cabbage, the CTO and calcified lesion. If you can win this arena, then definitely the number of lesion you can treat through a PTCA will be much increased, and patient can have freedom from cabbage. So yes, all the modalities are well explained and well said. So I really is very much benefited from this lecture, and thank you so much, Dr. Shirish Hiremath, for your wonderful presentation and sharing your experience. Thank you so much, sir.
I like the background, Dr. Kaiser, you have. It's like a tall mountain peak. I don't know if you're aware that you have a mountain in your background. So people
Dr. Kaiser, there is a mountain in background.
Yes, people who dream high, think high, they have these kind of backgrounds. So all the good luck in future.
Thank you so much. Thank you so much. Really appreciate it.
Sir, here Dr. Arun Maski from Nepal. Dr. Arun Maski?
Yes.
Yeah, Dr. Arun Maski.
Yeah, thank you, Professor Dr. Hiremath. After listening to your excellent talk, I don't think I have any questions. I learn a lot, and calcified lesions are really challenging, and listening to your lecture is always wonderful. You are a good teacher and good operator. Thank you very much for your excellent presentation, and thank you IPDI for bringing such an excellent topics. Thank you.
The calcification is notorious for perforation. So I think you have to expand the lesion well. At the same time, be worried that if you overdo, you would perforate the vessel. Like I showed you one case, even with an OPN balloon. See, OPN balloons are expensive. So the distal or the mid LAD portion was 3.0, the back end was 3.5. So we thought we'll take 3.5 to the distal part and inflate at 8 atmosphere, but even at 8 atmosphere, it sort of happened, the perforation happened. So I think you need to prepare the bed, and for that imaging is required. So calcified lesion, what we have learned, and that two hard ways, I mean, we've had lots of complication as we came up these years. So image, if you can, it sort of tells you. And if you can't image, always assume the worst. So be prepared. If you cannot inflate, the regular balloon cannot inflate, don't try to open with high and even higher pressure. The simplest thing you can do is put a wire on the side, which would act like a cutting balloon. And then so many times I take a non-compliant balloon directly. If I feel it's an elderly patient, take a small diameter balloon, like take a 2O non-compliant, go high pressure. That would make a huge difference in your thinking. So instead of taking 1.5 and start from very low diameter balloon, take a 2O and go high pressure as your first dilatation. And this paves way for all subsequent interventions.
We are happy, Professor Subair Rahman. Dr. Shirish, you know, Dr. Professor Subair Rahman is our senior teacher, so on the Pioneer International list here.
Yes,
Madam, Professor Subair Rahman.
Yes, Assalamu alaikum and good evening.
Assalamu
Can
alaikum.
you hear me?
Oh, yes, very
Yes,
well.
ma'am.
Nice to see you, Hiremath, again.
Yes,
You are a
after
good
many
teacher,
years.
no doubt about it. Each time I hear from you, and I just hear A to Z from your presentation is always good. You're nice and steady, and you win the race at the end. Very nice presentation, right? Calcification in the coronaries is a real nightmare. It can make your life hell if you are not really taking care of it properly. And you have highlighted that very nicely. And you have highlighted from using a plain balloon to shockwave balloon. And in the meantime, other devices as well. There's no doubt about this. This will help our fellows, junior doctors, even seniors, those don't have enough experience like you. Excellent presentation as usual, and I'm sure a lot of us, those who are still doing the intervention, will benefit from it. And bottom line is that you have to be really careful, very, very careful when you are dealing with calcification. Don't take it as a very easy job. It can make, as I said, your life very hell. Or if you, the way Hiremath has shown all of us what to do, if you follow, I'm sure, and if we have the correct gadget to do it, I'm sure you all will sail through as he has shown us. And I wish all my fellows, junior doctors and colleagues will follow these, and one day they will also do like him or maybe more than that. Thank you very much. Nice to see you.
Thank you.
Bye.
Appreciate your good words.
Thank you. Professor Khaled Mohsin, sir, is here. Professor Khaled Mohsin.
Yeah, thank you. Thank you, Dr. Hiremath, for your personalized words of wisdom and making it's a real master class. It's so simplified. It's a very complicated object. I have expecting some comments from you regarding the nodular calcification management when there is a sharp spicule of calcium protruding in the lumen, and which is likely to cause the rupture of the balloon. How to deal with this sort of situation actually when we are not having the proper imaging device in our hand. So would you throw some?
I mean, I was just praying and hoping that nobody asked me this question. But yes, we have to face it. Nodular sort of projection comes in one area itself. You will find the rest of the lumen or rest of the wall is quite good, but nodular projection is from one side. And whatever you do, you put pressures with a balloon, the pressure gets transmitted to the normal portion of the vessel, and the nodule does not get compressed. So this is the problem when you have dealing with the nodular calcification. IVL balloon with its kind of sound wave is shown to produce some impact on these nodules. However, one trick I would tell you is do a good bed preparation. Don't overdo, because, as I said, the pressure will get transmitted to the opposite wall, which may be healthy and might give way. So if you have a vessel like this, and there is a protrusion from here. Your stent can go like this and go over the nodule. So the stent should be well opposed. Though it is not fully expanded, it should be at least well opposed. I think this is one way in which, if you run into difficulty, like you have nothing more to offer, the nodule is not yielding, I would probably use pressures which are sort of adequate to make sure that the stent is well opposed, though not round in shape and well expanded. So you must end up with that at least before you come out. So do everything that you can possibly do. I mean, we've discussed everything, including rotablator, cutting balloon, and so on. And at the end, if you're still not happy with the full expansion and you are forced to put a stent, I think take care to expand the stent to the fullest.
I have
Thank you,
one
sir.
question. Hiremath, can I ask?
Yeah, sure.
Yeah, last 1 year you had this shockwave balloon experience. What about the perforation with them? Do you have any incidents of that?
No. I think shockwave balloon.
Have we lost him?
Yeah, I think he will come again. Lots of faculty here, but we can go our next cases. I think Dr. Shaira Parvin, Dr. Sahela Nasrin. Dr. Sahela Nasrin, do you hear me?
I can hear you.
Okay, Dr. Sahela Nasrin is the Associate Professor of Cardiology, Ibrahim Cardiac Center, Research Center. Dr. Sahela Nasrin will present a case from his live inbox. Dr. Sahela, please share your screen.
Is it visible, please?
Visible, yes.
Am I audible?
Yes, nicely audible.
Thank you. Honorable Chairperson, Co-Chairman, Speaker, and participant from home and abroad, Assalamu alaikum and good evening. My today's case is complex PCI in calcified vessels without rota by radial route. I'm from Ibrahim Cardiac Hospital and Research Institute. First of all, introduction. PCI of calcified coronary lesion represents a challenge for intervention in cardiology with higher risk of immediate complications, late failure due to stent under expansion and malapposition. So the outcome is poor, with high rate of target lesion failure, restenosis or thrombosis. The use of traditional or new dedicated devices for the treatment of calcified lesions allows better lesion preparation. So this is my first case, Mrs. A.B., who is 64 years old lady, diabetic hypertensive with history of prior MI anteroseptal in June 2020, hypothyroidism with history of COVID positive in August 2020, presented to us with compressive type of central chest pain with back and shoulder radiation and aggravated for last 5 days, and she's experienced it even at rest now. Her EKG revealed twin inferior leads and beyond to V3. Echo revealed region or wall motion abnormality with ejection fraction 40%, and other biochemical parameters was within normal limit. This is her CAG with subclavian tortuosity, and we approach to right radial root with 5 French T catheter. And here we can assume that there is heavy calcification as appeared as radio opacity without cardiac motion visible on both sides of arterial lumen as a double track. Same for RCA, which is also heavily calcified, and LAD seems to be occluded from its mid part. So cardiac surgical consultation was done, and also counseling of the patient part was done. They gave opinion regarding the PCI. So first we attempted the PCI to LAD, and XP 3.56 French guide catheter was taken. Fielder XT guide wire was negotiated by the help of microcatheter, and finally we succeeded to cross the catheter, cross the wear, and the filter XT was exchanged via microcatheter to Sheon blue. Then pre-dilatation was done by 210 NC balloon up to 60 atm pressure, followed by IVUS. This is the IVUS, which is showing that there's luminal calcification. It appears as bright hyperechoic lines with acoustic shadowing. And this is the picture after the pre-dilatation, and considering the IVUS, we decided to do sequential pre-dilatation with 2.5 into 15 millimeter NC balloon at 16 atm as there was high calcium load. Then we decided to deploy high calcium load and tortuosity of the vessel. And Rotablation was also kept ready if we was unable to deploy the stand. In that case, we proceed for rota, but luckily we could deploy the stand, and we deployed a disc of 2.5 into 38 millimeter up to 16 atm pressure by body weight technique. Then again, IVUS was done. This is the post-stenting IVUS. There is some kind of under expansion. So we decided to post dilate with 2.75 into 15 millimeter NC balloon up to 18 atm pressure, and this is the final angiographic view. Then we handled the RCA, and we took IR 1.5 into 6 French guide catheter, and we used Sheon blue guide wear. Again, pre-dilatation was done with 2.5 into 15 millimeter NC balloon up to 16 atm pressure. Then RC was stented by 2.5 into 30 millimeter disc at 14 atm with body wear technique. Initially, it was difficult to deploy the stent, and finally, we succeeded to deploy the stent. Then post-dilatation was done by 2.75 into 15 millimeter NC balloon up to 18 atm. Then post-procedural IVUS was done. Which shows there was good apposition of stent, and this is the final angiographic picture of RCA. So what we have done in case of lesion with high calcium content, balloon crossability was possible. So we did pre-dilatation and intravascular imaging by IVUS was done, as there was some kind of under expansion. So we did non-compliant balloon pre-dilatation, and finally optimal balloon expansion was possible. So we went for stenting, and we assessed the stent optimization by intravascular imaging like IVUS, as there was some kind of stent under expansion. So we did post-dilatation with non-compliant balloon. This is the algorithm of lesion with high calcium content. So In conclusion, we can say the problem of heavily calcified coronary lesions will increase in the future because of an aging population, increased rates of diabetes mellitus and CKD. An approach based on multimodal imaging techniques and the use of dedicated devices is key to improve patients' outcomes. Coronary calcification is a marker of advanced atherosclerosis and is correlated with multiple coronary disease and the presence of complex lesion, including long lesions, CTO, and bifurcation. Thank you all. Thanks for patience hearing, and special thanks to Professor Saidur Rahman Khan, who has performed this difficult case very nicely.
Thank you, Dr. Sahela Nasrin. An excellent job, and I think good result.
You're welcome.
Thank you. Thank you. Please stop your screen. Professor Amal Kumar Chowdhury, do you hear me?
Yes, Mohsin.
Yes, yes. Comment these cases.
Thank you, IPDI and Mohsin and Professor Wadud Chowdhury. Thank you to give me opportunity to say something. Good evening to everyone, including all the learned faculties, and also my very respected teacher, Dr. Shirish Hiremath. I'd like to expect the comment from Hiremath sir. There is some paper and some literature search, and in my institute also some students are doing thesis. The fluoroscopic calcification correlation between fluoroscopic calcification and angiographic severity of coronary artery disease. I like to expect your comment about this paper or this study, where the imaging facility is less. Can we expect whether it is rightly correlate the fluoroscopic calcification, the calcification, fluoroscopic calcification, if it is high, severity of the coronary disease is high. If it is less, severity is less. If it is correlate, which type of calcification? It is superficial or deep. So I like to expect the comment from the Hiremath sir.
See, when you see overall calcification on fluoroscopy, we should anticipate that there is a sizable calcium if you do not have any other imaging modality. So this is a general rule of thumb I would go by. And at least I would be mentally ready to sort of expect difficulty in balloon inflations and maybe take something else. The important thing comes because once you try to inflate your balloon and the waste is not going and you go high on pressure and you produce dissection, it becomes a relative contraindication for rotablator, correct? So I would probably feel that you try with a small diameter balloon, something like 2 or 2.5. Maybe you should take a non-compliant balloon to begin with. Whenever I'm expecting hard lesions, I take a non-compliant balloon to begin with. And that is one way you can sort of avoid dissection beyond the balloon limits. If it is restricted in that balloon length, you can always cover with a stent. But I would feel that you try, if the waste is not going, I think it's better to stop and switch to something else like a rotablator.
না না ওরকম কিছু না, এটা ট্রোপোনিমাই 2.5 3 গুণ বেশি, কমপ্লিট হার্ট ব্লক, এটা ইনফেরিয়র আমার কমপ্লিট হার্ট ব্লক দুটো হোক।
Thank you, sir. I'm requesting Professor Saidur Rahman Khan. Do you hear me?
Okay.
Okay, sir. You had a nice case. I think excellent outcome. Good result. Sir, you comment, Professor Saidur Rahman Khan.
My comment is actually talking about the calcification, especially just maybe for last few years. I think Dr. Hiremath is much more experienced, but I think for last few years, what I'm seeing, even in my hospital also, not as a statistics, but I can tell that calcification is getting too much a big percentage among the patients, even in the mid-age. Not, I can expect that one for the older age, but even in the mid-age people, maybe due to the environmental pollution or whatever it is, or vitamin D, some sort of or other mechanisms are there, but it's really very much obvious nowadays. Almost all the cases you can get some calcifications. And what my experience is here, almost 50% of my cases I'm doing, and I'm having this calcification. It's a headache, and it's like walking in the maze, because while doing a calcification case, and geographically moderate to severe, so you can predict that this is a severe calcification, and all the time you are getting alarmed by these things, whether as I'm fortunate enough, my cath lab is not like a poor man's cath lab. I have the imaging techniques, I have the imaging modalities, I have the rota, at least these things are here, but not all the time. If you are prepared to be with all these modalities to be used, then you are lost in the cath lab with 5 or 6 cases. That it's not possible. But sometimes what I'm seeing also, that that the calcifications, what you are seeing angiographically, and seeing a very nasty calcification angiographically, means moderate to severe, or sometimes very severe. And when I'm doing the IVUS and I'm seeing that 360-degree calcifications are there, but it's behaving like Renu Virmanis, that series of experiments there. He has told, she has also shown it, that the deeper the calcification, the more the arc 360-degree, then it is creating a stable plaque, rather than a nasty nodular calcification, which is very much prone to be SCS patients, and lots of complications may happen. And what I'm seeing, that these sort of deeper calcifications with 360-degree calcification looking so bad angiographically, but behaving so nice, like this, in this case, the case what Dr. Sahela has shown, that here the proximal calcification is almost 360-degree, but it didn't behave bad. All the balloons, stands, everything has been crossed through this part of the calcified area without any problem. But the problem is there when the nodular calcifications or speckles are there. That's the problem. So all the calcifications we need, so all sorts of modalities, starting from Rota, OPN, IVL, or sometimes and geographically not that much prominent calcification, focal calcification, can make your case a nightmare, which happens sometimes. So what I tell to my fellows sometimes, that whenever it's a smaller, simpler trick, is that if you don't have a rota, you don't have other modalities or imaging modalities, only thing what I can do at that time, that the balloon what you are inflating, the NC balloon 215 or 2.515, whatever you have, and then while the balloon dilatation was there, at that time I usually take multiple views also. So sometimes in one view, it seems like the balloon is uniformly dilated, but actually not. And that one can tell you a little bit about the might of the calcification, focal might of the calcification. Because after seeing that one, the balloon is properly dilated, well dilated, so I'm happy, so I can take a stand. Whenever you have put a stand and you have seen that there is a dog boring in the middle, then you are in a very bad state at that time. Because what you will do now, because what Hiremath was telling, that even in nodular calcification, you can put a stand, the stand has been crossed, and there are some positions, nodular calcification is there, so at least the stand has been opposed to the calcified wall. That's true. But if it is that much narrower, that means that the stand strut is making that space much narrower. So that material, so you have a nodular calcification in the background, and again you are putting a metal there, so it is opposed, but it is actually narrowing the lumen more. And at that time, when you have already stented the lesion, then you have no other way, because if you do a rota, then you have a rota. You don't have IPN, OPN, or you don't have IVL. So what you will have, you have only the rota. But rotablation of a stented segment is really very, very dangerous thing, and should not be, at least until, because all the stent materials will embolize distally, and it will be a big problem. So for the poor man's cath lab, this is very important to see the pre-dilatation balloon, how much it is expanded and how much it is inflating. And that one is one of the thing. And another thing is, I usually maintain for any calcified cases, I like to take a body wear. Even whenever you feel that you need it or you don't need it, it is helpful for cutting this calcium. It is helpful for taking a stand distally. For everything, it is helpful. Of course, along with the very good active and the passive support, both. I love active support more rather than the passive support, because I don't depend on the passive support all the time, because I don't know that whether a 7 French catheter will give a passive support. But if it doesn't, then it's bad.
Next question.
So I can say.
Dr.
Thank you.
I would like to add about the body
Yes.
wire.
Yes. Yeah.
Body wire is also important if you perforate. If you
Yeah.
perforate the vessel and the blood is going out freely into the pericardium, you need to block. And this blockage can be done if you have a body wire on the side and you quickly put a balloon on that and seal the flow to that vessel.
Yeah, 2 friends always better than 1 friend.
Yes.
Thank you, sir.
But they have to be friends. Huh?
We have the another presenter. Before that, we are happy, Professor Dr. M.M. Mohsin sir here. He is the most experienced interventional in Bangladesh. Also, highest number of cases done in Bangladesh. Professor Mohsin sir, your just comment regarding, yeah.
Thank you very much, Professor Hiremath and Sahela. Both of them presented in different ways. Professor Hiremath, he showed detail about the calcific intervention, and nothing to say more than what he said. As Dr. Kassar said, that the major cause of referral of coronary arteries to surgeon is CTO and calcification. That is very true. And one more truth is that the major cause of referral of calcific lesion to the another cardiologist by the junior is the calcification. Because junior might have a apprehension that there is a calcification. He may not have all the facilities in their cath lab. So fortunately, I got an experience of this sort of referral patient, for which I was planned and make ready for rota, everything. But this is my new way to handle this calcific lesion. Sorry. My technique is that for the junior, not the senior. My technique is that this is the modified balloon dilatation for calcification. It is a known procedure. Usually I take a 7 French catheter and 2 wire, and sometimes I prefer to take a Garcilla ready within the catheter. Then I proceed with a small balloon, non-compliant balloon, 8 to 10 millimeter, dilate the lesion initially at 10 atmosphere, slowly increase up to 20 atmosphere, stay there for at least 30 seconds, and take a fluoro loop to see the whole circle, as Saidur said, whole circle of the balloon to see any dog bone effect. If I'm sure that it is well expanded, then only I think to put a stent. Not all calcific lesion basically need rota. With the superficial calcification, there is not amiable with the balloon dilatation, that only 360 dilatation, 360 calcification usually need rota. But most of the cases, it is not 360, scattered, superficial, along with the deep calcification. Deep calcification is so much, it is more horrifying the operator how big the calcification. But to me, the superficial calcification is more dangerous than the deeper calcification in terms of expansion of the vein. As we don't have yet the facilities for opium balloon or IVL, but still I use Rota for all this calcification, and I'm sure that the junior, those who are trying to handle this calcification, at least if the scattered calcification and there is not superficial calcification, they can practice to deal this calcification by this technique. Put 2 wire, take a small non-compliant balloon, dilate more than 30 seconds, and see the full circumference of the lesion by fluoro loop. And when you are sure that this vessel is fully dilated, then you could prepare for the stent. If necessary, you can take the advantage of the Godzilla for smooth covering, smooth tracking of the stent. The 2 wire is important not only for the cutting effect, but also, as Saidur said, it's very easy to track the stent. But don't forget to remove the second wire before putting the stent, because it is a calcific lesion. Normally, non-calcific lesion, the wire can easily come out. But in calcific lesion, by mistake, if you place the two wire together, and if you inflate the stent, it may come with a different scenario. So don't forget to remove the second wire before putting the stent. There's a small tips that I've learned from myself, and this is for the junior.
Thank you.
And once again, thank you very much, Hiraman, about the lecture that he has given, an excellent demonstration of all the tips and tricks to handle the calcification. And also thank you, IPDI, especially Mohsin and Wadud, to arranging this sort of interesting session for not only junior, for all the interventionists. Thank you very much.
Thank you. Our next presenter, Dr. Kalim Uddin. I think he is an excellent case. Dr. Kalim Uddin is the Assistant Professor of Cardiology, National Heart Foundation and Research Institute. Dr. Kalim Uddin.
Respected moderator, and chairperson and guest speaker, Assalamu alaikum and good evening. I am Dr. Mohammad Kalim Uddin from National Heart Foundation Hospital and Research Institute, presenting a case on rotablation. An endless stay. A 60-year gentleman, hypertensive, smoker, non-diabetic, underwent CVG 2 years back for critical triple vessel disease, presented with progressively increasing chest pain, CAG, CABG, and check CAG was done in abroad. His left ventricular ejection fraction was 45%. Coronary angiography report. And there is a coronary angiography shows 80 to 90% stenosis in distal segment of left main coronary artery, 70 to 80% stenosis in proximal segment of LAD, OM1 totally occluded at its ostium, L6 free of disease and free of significant disease, RCA dominant vessel having 80%, RCA dominant vessel having 80% stenosis in mid segment, and PDA totally occluded and in its proximal part. Graph angiography showing SVG2 PDA block and SVG2 OM having 50% stenosis at the anastomotic site. Lima to LED block. And we decided to do a PCI of right coronary artery at first. We inserted temporary pacemaker. And RCA was wired with floppy wire. And predilation done with 2 into 15 millimeter non-compliant balloon. And again 3 into 15 millimeter non-compliant balloon. And image after predilatation. And then we inserted deployed a 3.5 millimeter into 38 millimeter non-drag lifting stent from proximal to mid RCA, inflated at 14 atmosphere. Image after stenting and post dilation done with 3.5 into 15 millimeter non-compliant balloon And RCA was well vascularized, revascularized, and with good distal flow and giving some collaterals to LAD. Now severe calcified left main stenosis involving proximal part of LAD. Coronary artery calcification, especially in the left main coronary artery, imposes a big challenge for PCI in terms of vessel rigidity and device delivery difficulties. Rotablation with the ability to differentially ablate calcified and fibrotic plaques is particularly useful in these lesions. Wiring of left main to LAD with floppy wire was failed, and then we took pilot 50 wire and wired with the help of coronary microcatheter. Then exchange with rota wire. Rotablation done with 1.25 millimeter bar. And after IVUS study, this showing horseshoe appearance of calcification, and we step our bar with 1.5 millimeter. And then rota wire was exchanged with microcatheter with floppy wire, and L6 was wired with floppy wire. Then pedalation from left main to LAD was done, and then pedalation with 2.5 millimeter into 15 millimeter non-comparable in proximal LAD. And balloon burst inside the vessel during high pressure. And then again 3 into 9 millimeter non-compliant balloon inflated at 22 atmosphere, and after pedalation image. And we have done IVUS study, and IVUS which shows LCX origin is free of disease. So we decided to do single stent strategy. A 4 into 34 millimeter dilating stent position from ostium of left main to LAD. And we took several views to see position of the stent and inflated at 12 atmosphere. Just immediate after stenting. And we reward LCX through stent start. And see that stent starter is open as evidenced by balloon freely moves. And then post dilation done with 4 into we remove gel wire, and post dilation done with 4 into 10 millimeter non-compliant balloon. And IVUS study showed that dissection of a stent edge and also lesion. And then we put another second stent 3 into 26 millimeter drug-eluting stent and deployed stent, and post dilation done. And post dilation done in left main portion with stent with 4 0.5 into 8 millimeter non-compliant. Angiographic result, and angiography shows is stent are well looking and stent is well approached in IVUS study. Now scenario of rotablation in our hospital from January 2015 to December 2020. Total 263 patients underwent rotablation in this period. Most of the patients were above 60 years, and 73% patients were male. Hypertension was the most common risk factor, followed by diabetes and smoking, and 63% patients were chronic kidney disease. And 85% cases there was diffuse calcified lesion, and 75% total cases are complex cases, most complex cases, and we used IVUS in 27% cases. And we have done follow-up, mean follow-up is 30 months, and 88% patient doing well. Symptom relevant check CG was done in 40 patients, and ISR found in 0.8% cases, and mortality is 10.3%, and overall MACE is 11.1%. 1%, 0.1%. So take-home message is patients with calcified coronary artery disease often tend to be elderly with multiple comorbidities. Elderly patients who had prior CABG are also in unfavorable anatomical conditions for repeated bypass surgery. Rotablation is an effective technique to tackle such complex calcified cases. After rotablation and proper lesion preparation, new generation days can optimize outcome. For optimizing outcome, imaging is essential. Thanks to organizer for giving me to present this case. And rotablation is an operator and team dependent procedure. So from our Cathlab teams, thanks to all. Thank you.
Thank you, Dr. Kalim. Excellent case and excellent outcome. Dr. Shirish Hiremath, please, few comments. Dr. Shirish Hiremath.
Yeah, I think all steps are just the way a good operator would take, and I'm very happy that the result was also very nice. The judgment is very important to anticipate calcification. If you're doing IVUS or OCT, it's so obvious, but even otherwise, long duration diabetes, CKD, I think we should learn to understand that these would be hard lesions. So mentally go with the preparation that you will be using a non-compliant balloon at high pressures and so on. One little word, when you're going to use very high pressures like 30 on a non-compliant balloon and 45 and 50 on OPN balloon, you undersize a little bit, like if your vessel is 3, go with 2.5. We want to dilate the narrowed portion and not the regular diameter area. So that area will be very small, narrow. So 2.5, half size less, going full pressures would probably safer than 1-to-1 and going full pressures.
Thank you, sir. Dr. Ashok Datta? Dr. Ashok Datta. Dr. Ashok Datta, do you hear me? Dr. Ashok Datta?
Yeah.
Yes.
Thank you, Dr. Mohsin. Thank you, IPDI, for arranging such a great session. I'm Dr. Ashok Datta from Heart Foundation, and thanks everybody. So this is a great session. Regarding the last thing that Hiremath sir was telling, the undersizing of the non-compliant balloon or OPN balloon. Sometimes we anticipate that calcium is there, and after pre-dilatation, after stent implantation, we see that there is a part of the stent is not opening well. So in that circumstances, is it wise to take a undersize like 3.5 stent is placed? So to inflate the particular segment, to open up the particular segment of the stent, is it wise to take 3 millimeter short non-compliant balloon, sir?
I think let's give importance to that word short. If you're taking a short balloon and putting precisely at the most critical portion, which is not giving way, I think it would work well, because that short length, of course, there's a possibility that it may slip forward or it may slip backwards. But if it stays there and if you're able to get a pressure of 30, I think you would definitely have done a great job, and the lesion would expand. Now, if you are going to take 1-to-1 diameter based on angiogram, you could be mostly correct, but if you have done imaging, I think the importance should be given to the diameter measured on imaging. And based on that, you take a balloon, non-compliant balloon. Luckily, we have quarter sizes also available. The OPN-NC balloon, the high pressure balloon is not available in quarter sizes to us. I don't know whether it is available world over, but I think a day would come when we'll have quarter sizes also. The important thing is the balloon quality should be such that even if you move pressures from say 20 to 30, It should not grow in size. If it grows in size, it is bound to hurt the vessel. If it does not grow, it will exert a pressure and will probably crack the calcium.
Thank you, sir. I have one question to you. May I ask you?
Sure.
Yes, yes, sure.
Regarding shockwave balloon and rotablation, both are good option for calcified lesion. So for shockwave balloon, we don't have any experience. How do you just predict that this place or this type of calcium, this type of coronary shockwave is better than the rotablation, or both can be used in the same setting?
Actually, we'll answer your last part, whether both can be used in the same setting a little later. But let's understand that if you have a lumen and calcium is inside on imaging, if you see inside calcification, luminal calcification, rotablator works very well. Also, if there is very tight narrowing where your balloon is also not going, rotablator will go, but your IVL balloon will not go. It's quite a bulky balloon. So for IVL to go, you need to make a preparation with the balloon first, then take your IVL balloon and then go to a pressure which is between 4 and 6, preferably 4, deliver your shocks wherever you want to. And after delivery, increase your pressure to 6. That's how IVL is to be used. So 4 when you are delivering, make it 6 before you deflate. And that's how you use an IVL balloon. So if the calcium is deeper, the lumen, as we discussed, is with rotablator. But if it is a deeper calcium, more towards adventitia, it is well addressed with IVL balloon.
Thank you, sir. Dr. Pradeep Karmakar, Dr. Pradeep Kumar Karmakar. Dr. Pradeep, do you hear me?
Yes.
Yes.
Thank you very much, IPDI, for arranging such a nice programs. And also very much thanks to the Professor Hiremath for his nice deliberation. I have few questions. You know, the recently EVL, European Bifurcation Club, declared that in distal left main bifurcation stenting, when we are doing the crossover stent, then the LCX ostium should be opened up by the balloon. What is your opinion and experience? Second question is, most of the time, I've seen that you are using the culotte technique very much in frequency. What about the decay crash? Last question, what we expect, oil expansion or oil apposition? Though we are trying to get the both, but if one, which one we will expect?
Let's start from the reverse, expansion and apposition.
Yeah.
We like both, as you mentioned.
Yeah.
Like the stent should be fully expanded and well opposed to the vessel wall. What you may not achieve is apposition has to be achieved. Expansion you may not be able to achieve, like say nodular calcium. You may not be able to achieve a full expansion, but apposition would be there. So apposition is easier to achieve and you should not fail to achieve apposition. Expansion sometimes difficult, like if you have not prepared the bed properly. See, the expansion is a quality, depends on how well you have prepared the bed. So always spend time in preparing the bed, make sure that the balloon expands fully so that your stent is ready to come in. If the balloon shows some kind of indentation, it means it has not expanded that portion very well. So in that case, you use a cutting balloon, or if you do not have a cutting balloon, put a wire on the side of the conventional non-compliant balloon, which may act like a cutting. And that's how you get rid of the area which is giving you maximum resistance. So these are the two things coming together. Your first question, I forgot.
During the crossover technique from left main
to
L.
The whether the side branch needs to be addressed, or you can leave it alone. I think there are many people who think in different ways. I think let me explain to some of the juniors that Dr. Pradeep is asking if you put a stent from left main to LAD, and then you have a circumflex which is looking very good at the end of stenting. You are done a part, the circumflex mouth is looking very well, no narrowing. Do you still need to address the side branch? I would probably go by the feeling that you don't need to address. I would do it for a young person, like somebody who is 40 and you put a left main to LAD stent. You never know, at age 50, he might be needing to go to the circumflex for another fresh lesion. So it is better to do it today than do it later. Like 10 years later, when you want to do circumflex to open up these struts, which is a 10-year-old stent, is not a very good idea. So to do a favor to your son who may be studying cardiology, you should open up the stent to the side. So I would feel if it is a younger individual, I would like to open these struts. Also, you must have heard some OCT presentations. If your stent strut is across the mouth of the circumflex, the stents, when it gets endothelialized, the endothelium actually grows on this stent strut.
Yes.
So it is bang in the center, it would probably obstruct the subsequent growth. So I think when you're doing the first time, it's a very easy step. Only thing is, if this is your main branch stent, and if you want to bring a side branch stent, don't get it deep. Just stay at the mouth so that you are dilating only the strut, okay? And not you're not touching the circumflex wall.
Yeah. Yeah.
Thank you, sir.
And there was one more.
Mohsin,
Yeah.
I have yeah.
Okay.
Dr. Hiremath, just the thing is that when I don't have IVL yet, I don't have OPN yet, but
To make it short,
you know that,
but
at the same time, wherever you are doing the rota for a case, and in case of rota, it is told that 0.5 to 0.6, the dimension with the vessel diameter. And so that is like that it's a 2.75, and then you are taking a 1.5 maximum rota, not more than that. Whether you like to upgrade the rota bar?
No, I think rota is probably used to modify the lesion morphology. So we are not trying to achieve a very good, nice.
No, what is the ratio that choosing the rota bar?
As you said, 2/3,
0.5 to
6.
Yeah. So then I have done it, but then after rota, usually we do a post dilatation or a dilatation again with an NC balloon with the reference 1:1 reference diameter.
Always.
So when you have done it, that yet the calcium is not cracked.
You mean your balloon still has an indentation?
Yeah. So then you don't have an IVL and you don't have an OPN at that time, because you can't stand that one even after rota, because when you are feeling happy that your rota will give you the happiness, but it has given you the despair. So at that time, what else you have, like the cutting balloon or the scoring balloon? Even if it doesn't, then what will happen? You'll go for again the rotablation or anything else?
I mean, there is no harm in upsizing the Burr and going to 175 Burr. But this can also be achieved with a cutting balloon, as you said.
Okay.
So if you're already done with 1.5, I would rather use a cutting balloon and not go higher with a big Burr.
Thank you, sir. We are done. We are 2 hours time. Thank you, sir, being with us. 2 hours from the West of 9 o'clock now in Bangladesh, 11 o'clock. Thank you, everybody. Our expert panels are here. Thank our participants being with us last 1 year during Corona pandemic. I'd like to thank Medtronic, who sponsored the program, also Bixim Pharma, Thank you, everybody. See you again next Thursday at 9 p.m. with the another faculties. I like to Dr. Shirish Hiremath, few comments and last comment from you. Then Dr. Abdul.
Actually, this was an exciting session. I always knew that the doctors in Bangladesh are very enthusiastic about the learning process. Every time I was giving some kind of discussion in between cases, I used to have a gathering of at least 10 who would be eager to listen to what we are discussing. So you have a very good substrate in terms of very enthusiastic cardiologists. And I'm sure one day they will take Bangladesh to the top line across the globe. So all my good wishes. And I have personally, on personal note, I have lots of friends in many of you whom we have met together at various conferences, discuss cases, discuss complications, got into complications and so on. Some of you have also attended our CAD meeting, CAD, which we have in Mumbai every year. I mean, Dhaka is one place where I feel very much at home every time I visit. So thank you for this invitation. And the level at which the discussion went throughout last two hours, I think was outstanding. I think both the cases which were shown were really, really interesting. And I would be very proud getting that kind of results myself. So I'm really, really impressed the way the progress in intervention field is happening in Bangladesh. I've been coming to Bangladesh for almost 10 years now. So I have seen the early phases. I have seen the early phases in India too. So I know how the angioplasty progresses. It's a hard work for many of the seniors who actually ventured to do angioplasty under complex adverse situation, a non-availability of so many things. But I think I mean, it is their sweat which is enjoyed now by the youngsters who have most of the things available to them, and they can come out with good results. It's a good thing on the overall front that availability is becoming easy. Angioplasty success is getting close to 100%. And very importantly, the long-term results are also getting better and better. So ISR cases clearly very few these days compared to what we used to have in early days. So I always tell my patients, if he has a multivessel disease at age 45 or 50, always angioplasty first. If I can't do an angioplasty, then he goes for surgery. Because once you do surgery, the advance of disease in the native vessel is very rapid. They get totally blocked, they get calcified, and to do angioplasty for somebody who had a bypass, say 10 years or 15 years earlier, is really, really very tough. So I would always use angioplasty as the end options, like patients very young, like 40ish, or patients who is very old, like 8ish. There I would definitely use angioplasty, even for multivessel disease. Patients most of the time goes for surgery in my practice are around 75 to 65 age group. So you do one good surgery, they get about 15, 20 years. So they are beyond 80, 85, and then whatever comes their way, we could offer them angioplasty. But most of the time, their activity requirement is quite small and they're quite happy not wanting to do any procedures. So I would give age as a huge importance in decision making, whether it's an angioplasty or whether it's a bypass surgery.
Thank you, sir. Stay safe and take care, sir. Thank you. We wish you good health, sir.
Thank you
also,
for the
thanks,
invitation.
Thank you. Thank you, Dr. Kalim Uddin, also Dr. Sahela Nasrin, being with us. Professor Wadud, sir, please conclude our session.
It was a really pleasurable session.
We have seen beautiful cases done by our youngsters, and we have learned a lot from a very veteran cardiologist who is very well known to us. I hope despite 2 hours of staying together with us, you have enjoyed the session, all of you, our esteemed panelists and also the participants who have joined with us. And hopefully, again and again, we'll be listening to Dr. Shirish and faculties like him, who are really very dear to us. Thank you, sir, and thank you, audience.
Thank you indeed.
Thank you. Thank you.
Good night.
Thank you. Good night. Thank you, sir.
Good night.
Good night. Thank you, sir.